Good afternoon, but also good morning and good evening to some of us. It is our pleasure to welcome you to the 6th ITM alumni webinar focusing on COVID-19 in the Philippines, opportunities and challenges for intrapartum and newborn care. In the ITM alumni webinars on COVID-19, ITM alumni present their impressions on the current situation of the outbreak in their country and highlight how they are engaged in this global fight against the pandemic. The main aim of this series of webinars is to share experiences, expertise, and good practices within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. Our today's moderator is Professor Dr. Lenka Benova. Lenka is Professor Maternal and Reproductive Health at ITM. She's a population health scientist with a focus on reproductive and maternal health-seeking behaviors and quality of care. She and the team at ITM have been conducted a global study on how maternal and newborn health providers have been affected by and responding to the COVID-19 pandemic. Please, Lenka.
Thank you, Charlotte, and good morning, good day, good afternoon, good evening to those of you who have joined us today. It is my great pleasure to introduce our MPH and Emerging Voices alumna, Dr. Romelei Camiling-Alfonso, or as we endearingly know her as Lei, who has been involved in the SARS-CoV-2 response in the Philippines as a technical specialist from the Philippine Society of Public Health Physicians. And she's active in technical groups related to health policy, systems strengthening, and strategy. And it will be a fantastic presentation, very in-depth case study of how she has been involved in the response to the COVID pandemic in the Philippines, and particularly in developing operational guidance or guidelines for treatment. So what Lei had asked us to do at the beginning just now is to share a short video produced by the World Health Organization that talks about breastfeeding during the COVID pandemic. So I'm going to ask that we play that, and after this we will ask Lei to start with her presentation. Thank you very much.
WHO recommends that all women should be supported to breastfeed. If COVID-19 is suspected or confirmed, these hygiene measures can help protect the baby. Washing your hands before breastfeeding, coughing or sneezing into a tissue and disposing of it immediately. Cleaning and disinfecting surfaces you have touched. Wearing a mask where possible. If a mask is not available, WHO still recommends breastfeeding, as benefits outweigh the potential risk of transmitting the virus.
Good afternoon, good evening, good morning, everyone. Wherever you are right now, thank you for taking the time to be here to join us in this important discussion. Apologies for the technical difficulties. The Philippines, I think, has one of the slowest internet connection in the world. And it's 8 p.m. here. Everyone is trying to connect. So without much ado, I am very much happy to present to you the work that many of my colleagues and I have been doing. This is this part of the work that we do, and despite the challenge and the difficulties that we've had in COVID response, we have also seen opportunity for collaboration and system strengthening. Thank you, Jan, for controlling my slides. So briefly, my objectives here would be to identify key challenges in maternal and newborn health care, describe evidence and policies that are relevant to these key challenges, Well, these include also the controversies, and then zoom in on the Philippine response in terms of harmonizing policy and practice through clinical practice guidelines that aligns national policies, evidence, and recommendations globally, and sync them with operational realities in our setting. And most importantly, all of these guidelines in policy and practice should be able to incorporate shared decision making between health professionals, and in this case, between women and their families. Next, please. I would like to jump off from Professor Benova's study. It's ongoing, and we would like to look at how COVID has presented challenges in the health system, but most importantly to the frontliners. And they've gathered a global survey wherein 81 countries participated, 714 maternal and newborn healthcare providers. And they've done an excellent thematic analysis of what they have been going through. And they've seen that, next slide please, healthcare professionals lack practical guidance on how to deal with patients showing symptoms of COVID-19. Only 1 out of 3 received training from their health facility, while nearly everyone searched for information for themselves. And 1 out of 2 LMIC respondents receive updated guidelines, in contrast with 82% on those in high-income countries. And 47% and 69%, half of them felt most knowledgeable in how to take care of COVID-19 for patients that are in maternity, in the maternity wards. And here, what we see, health workers need guidance, and though they receive information, they still lack the confidence. And they have seen also that 90% of respondents reported higher level of stress. There's an alarming decline in the use of and in the access of services. So they have seen that women are afraid to come to the health facilities for fear of getting infected. Healthcare providers are unable to reach their workplaces. We know that there have been quarantine measures across the globe, and even health workers are unable to reach the workplaces, not just the patients. And this decrease has somehow been compensated by remote tools. Next slide, please. And there's a compromise in the quality of care. So these themes have been seen as trending across the globe, and they've seen that there are changes in policy and practice that may not be necessarily evidence-based, such as the following. And many of these may have short or long-term negative consequences for mothers and newborns. So the progress that we have made is being reversed in terms of all of these evidence-based guidance that have been in place and practices. So next slide, please. So it's a tough balancing act when we talk about COVID response. First, for the health system, you need to keep up with the demands of COVID-19 response, which is not very clear to everyone. At the same time, you need to maintain essential health services, and while at the same time maintaining the health system so it doesn't collapse. But all of these health system interventions, they would fall on the shoulders of your healthcare providers, wherein while you want to provide quality care, you have to also ensure your personal safety and well-being. However, when we talk about women about to give birth and their newborns, these are patients that are not sick, unlike many of those who come into the health system. So there's an intersection of COVID and non-COVID care, and how do we balance all of these things when we do our COVID response? Next slide. So here, when there is a lot of uncertainty, when you want to care for your patients, but at the same time, you want to take care that you don't get the infection and you don't have the proper guidance, fear can be a knee-jerk reaction. In many of the countries, there's been a lot of separation that has happened between mothers and babies, and this can be motivated by different factors. Next slide, please. Okay. So when we talk about those decisions at the point of care, we want to go back to patient-centeredness, and there's a definition here. But in maternal and newborn care, we're not just dealing with the patient. We need to deal not just with the woman, but with the entire family. Of course, the baby is there, so there are two, the mother and the baby. And when we talk about woman or family-centered care, we need to be able to provide not just access, continuity of care, and technical effectiveness, but we need to be able to respect patients' preferences and provide the support that they need in order to make those decisions. Okay. So next slide, please. Yeah, it's a little bit, it's slowing down a bit. Thank you for your patience, everyone. So when we talk about maternal and newborn care, the intrapartum period is quite unique because you cannot really separate the mother and the baby. And because of that, you need to have a lot of coordination and negotiation, I might even say, between multiple stakeholders and decision makers. And not only that, as I mentioned earlier, mother and baby here mostly come to you not as sick patients, but they're a healthy unit, they're healthy package. And how do we maintain that? How do we keep them healthy? Giving birth is not an illness. It should be a happy event. And so here we need to coordinate action between the obstetricians, pediatricians, anesthesiologists, even especially when you talk about cesarean sections, midwives, public health managers, of course, most importantly, with the mothers and their families. In the Western Pacific region, where the Philippines is located, we have the first embrace, which is a set of 4 simple, evidence-based and cost-effective steps that benefit all newborns, including sick, preterm, and those who are born by cesarean section. So when we talk about these steps, can you please go to the next slide? We are talking about immediate and thorough drying, early skin-to-skin contact, properly timed cord clamping, and non-separation of newborn from mother for early breastfeeding. So this policy has been in place. For example, in the Philippines, it has been institutionalized since 2008. So it has been more than a decade since this was in place, and it is in policy, and it is the standard practice of care. So next slide, please. And when they look now, the evidence of the benefits of this package of interventions, here we see a study from Vietnam, next slide, that have shown that having the intervention actually increased exclusive breastfeeding rate from 49% to 88%, increased kangaroo mother care, decreased sepsis, and decreased NICU admissions. So next slide, please. And we want to go back to the basis of those individual steps, wherein here we see that delaying initiation of breastfeeding increases the risk of infection-related death. Here in Ghana, 10,000 babies, you see that the longer that it takes for the delay, the higher the relative risk. For day 3, if you might see here, it's about quadruple. And then you go, next slide, please. In 2008, you have a study now from Nepal. You see a similar, the gradient, you see a similar pattern of increase in risk of infection-related death. And this is 22,000 babies that are breastfed. Next slide, please. So what does this mean? Interventions are time sensitive. You see, for example, here, the delay of less than 24 hours already doubles the risk. And if you delay by 72 hours, around quadruple the risk. And what if, because of COVID, we separate the mothers and the babies, what will be the impact of 14-day separation be? And we have to weigh that. So next slide, please. Further, non-separation increases the chances of exclusive breastfeeding. For example, in this case, if you just increase the non-separation or not, you keep the mom and the baby together for just an hour or so, you already double the odds of chances of a successful exclusive breastfeeding without even doing anything, without even doing counseling, just leave them be. Right. Next slide. So I've already shared with you the recommendation of WHO, and it remains, no, breastfeeding still is still the standard of care, and we will still do skin to skin contact, and we still recognize the harmful effects of inappropriate infant formula milk. So next slide. All right, I've shown that video already, and this is just one of the latest studies that shows even that in breast milk they found that the RNA does not represent replication competent viruses, and it's not likely to be a source of infection for the infant. This is the latest evidence in terms of the presence of the virus in the milk, breast milk. Next. Okay, so here we just want to state this categorically. All right. There's no evidence to support that early separation improves outcomes. So separation may actually not prevent infection. If you look at it, you are having twice the burden by separating the baby from the mother. You are requiring 2 sets of caregivers, both in the hospital and at the home. You need protective equipment for them, hospital rooms, even also at the home, you need to separate them. And of course, if you separate, there's interference with the benefits of skin-to-skin contact, the disruption of breastfeeding initiation, and if it's 14 days, then you're gonna have to find an alternative feeding option. Of course, many of us here who would be involved in lactation counseling would know it's not as easy to switch on and off your hand expression. So of course, this can also cause extreme stress on the mother and on the family, right? So next slide. Now, why did we start with setting that stage? Because in the Philippines, there has been an ongoing movement among the different medical practitioners. Because next slide, please. Right. We have a Viber group. I don't know in your countries, but in our country, of course, the Philippines is known for loving social media, and we have Viber groups as a means of communication during this crisis. So there is a group of volunteers that's helping Department of Health. That is my friend, Lopao, Dr. Lopao. He's a professor at the UP College of Medicine. But what they do is actually voluntarily moderate an open group. No, it's actually a filtered group of health workers wherein at certain times of the day, they allow interaction and they respond to that based on the current evidence, issuance, and policies. And they've been doing it from the beginning. And some of the maternal and child health concerns there have been collated. And if you would look in the Philippines, the health workers are asking for guidance. So for example, here, do we screen all patients? Provide us with guidelines. Do we follow WHO? Because there has been a different guidelines from other societies. And what is the consensus? And what we do when the screening is positive. But in fact here, the screening here, we don't even use screening in the country, but they ask, right? And yeah, you will also get insights there, like the cost for giving birth has been jacked up, like double the price in some hospitals because of the COVID. All right. So because of this Viber group, we get instant feedback, and we also are able to get the feel of what health workers are really looking for. And here we found out that they are looking for guidance. Next slide, please. So that is for the healthcare worker side. Here we see in the headlines, there was a mother who chose to give birth at her house. This is in Metro Manila, the capital. And she was helped by a midwife. 5 hours later, she died. Nobody took her in, right? And she was rejected, postpartum bleeding. And this is quite unfortunate because you see the quality of care is really compromised. You see mothers refusing to go to the hospitals because they fear. And then you have midwife who is, well, this is actually against our law to deliver a baby at home, but they're left with no choice really. So what do we do in this situation? Next slide. So what we have done in our group of medical professionals, we see that clinical practice guidelines can actually improve the quality of care. So there are tools for task shifting, clarity of thought, and decision making. And there are recommendations that are intended to optimize patient care. Just don't say, okay, screen everyone. No, you have to do a systematic review before you recommend that. You have to do assessment of benefits and harm of alternative care options before you put it out, right? And you have to reduce inappropriate variations in practice to ensure more efficient use of limited resources. Next slide, please. Pre-COVID, before COVID, what was the situation like in the Philippines? So it's quite fortunate because before COVID came, there were studies that have done in terms of putting in place, having quality clinical practice guidelines institutionalized in our system. So out of 87 clinical practice guidelines reviewed, 50% only use an international accepted approach. And if you look at here, 31% had plans to update, 50% had outside sources of funding, and 26% only declared conflicts of interest. So the findings of the initial study on clinical practice guideline development in the country showed that the Philippines is constrained by inadequate human and financial resources, and it suffered from unmanaged conflicts of interest. There's an inadequate dissemination and impact evaluation, and there's a need to have a manual oversight so that we can have high quality and equitable CPGs. Next slide, please. So this is just how CPGs are done. So first you have to prioritize a topic and then look at all the evidence and then generate the CPG, appraise the evidence, disseminate, and monitor and evaluate. So you might think that this is quite a tedious process. In fact, it is quite tedious. So how do we solve that? So next slide, please. All right, so why do we want to have this kind of process in guideline development? Because this is the behavioral framework. You want harmony, you want people to actually adopt it and do it so that they will be one in terms of what they do and they're guided in terms of what is the best available evidence. So by having this step, the guideline development step, they are co-owners, in fact, of the decision to actually put out this recommendation, and that will facilitate your uptake and your compliance, if I may say that. Next slide, please. So the good thing here is that we already have a CPG policy in place. We already have the manual, right? We have it in place in the Philippines before COVID. So next slide. Right. However, COVID-19 requires agile response. We cannot go through all the approvals and et cetera, because evidence is quickly evolving. We need living documents and rapid consultations. We need rapid recommendations, but that should not compromise or bypass stakeholder consultations. And we need harmonized actions, because if we give out conflicting recommendations. For example, one of the questions earlier, who do we follow? Do we follow WHO? Do we follow this society? So there is confusion on the ground, and that will compromise the quality of care. So what we saw here is that technology facilitated our quick response. Because as I mentioned, there's already an explicit CPG development process in place, but the technology allowed us to remotely work together, have remote consultations with the proper experts, have dissemination, and then have feedback and update easily. I'll discuss this further later. Next slide, please. All right, so enter our unified COVID algorithms. So this group, you would see all the different logos there. The Philippine Society of Public Health Physicians is there. These are all clinician groups. But fortunately, we were able to come in there to put in our public health lens and to bring in primary care perspective also. So you see here, there are 4 sections: guidelines for primary care, guidelines for hospital care, guidelines for PPE use, rational PPE use, and guidelines on return to work. So we all work together in a technical working group, which is on Viber. So what we do here is to standardize format to prevent confusion, so that they can interlink with the different clinical decision pathways. So for example, if you want to refer to another pathway, then it is consistent with the next one. They can talk with each other. It doesn't matter what the specialty society who developed it is. And these are updated based on evidence and policy. So as a matter of design, we did not make the algorithms downloadable, but we made them available online, and so that whenever there are updates, they don't circulate, like there is always a version control. So what is most important here, and I'll show you later, is that it's framed with the Philippine context in mind. So we have very limited testing capacity, and we realized very, very early on that many of our frontliners were stuck because they didn't have any RT-PCR. So we took it out of the way and we put it at the very tail end and provided evidence-based guidance on how to go about the decision-making, even without testing. And we also put in here like the rapid diagnostic kits, which can be quite controversial, are not part of the decision-making pathways, as consistent with what current global evidence says. Okay? So because of their limitation in terms of use. Okay. So here, next slide. So here, these are the contents of the primary care guidelines. You have there the classification of cases, community quarantine, contact tracing, and then we put in here the management of pregnant patients and newborn care. So here, you would see that they would interact with one another because they're not mutually exclusive in a way. And so everything is consistent with each other. So next slide. However, we have now a blank space for figure E, which is newborn care, because a major revision is ongoing. Next slide. Right. So we want to focus now on the newborn, maternal and newborn care implications. So how many people does it actually affect? It's an estimated of 142,000 Filipinos born every month. So 142,000 Filipinos would be benefiting or be harmed by whatever policy will be put out. And so it's very important. Most of these, based on our estimates, would be born in community-based facilities, meaning to say not special tertiary care facilities. Right. So it's in the primary care setting, community-based settings. Next slide. Very early on, there was a policy before there were unified guidelines. There was a policy that adopted another set of guidelines. Next slide, please. So here you see the specialty societies have come up at that time because the available evidence at that time was Wuhan. And so the policy guidance assume that all moms and babies are suspect until proven otherwise, and they have operational implications, like all deliveries include PPEs. And then back then, again, the evidence then was still Wuhan. There was no other guidance available. Separate the baby from the mother in different isolation rooms. This is until both mother and baby return concordant. So the test would be both negative, right? All right. And if the testing is not done, for example, you're in an island somewhere in the Philippines and you have no RT-PCR, then you'll have to separate for 14 days from resolution of symptoms or exposure if mother is asymptomatic. So here, the baseline policy back then was a separation. And in fact, up to now, this is still an ongoing discussion. Right, so there are key assumptions here, like there is timely PCR, and there is an intent. The intent is to prevent transmission to the newborn and healthcare providers, availability of isolation facilities. There are alternate caregivers who will not transmit the virus to the baby, and at home, separation is still possible. Like, because if you separate them just at the delivery and you cannot sustain the separation for 14 days, it's going to be difficult. Like, for example, when we asked one of the urban poor mothers, when we did this, and she realized, oh, when they get home, they need to take care of the baby who's separated, and nobody's going to take care of the baby because the father has to go and find a living and go to work. So that also means that if we separate, then we have to find sustainable alternative feeding option. So these are the things that had operational implications on the initial policy. Okay, next slide, please. moving forward. So because of that, there was a lot of discussion. And so we stepped in, our group stepped in to actually support the government and the medical society so we can unify and harmonize what is currently available as evidence. And so we can move forward and incorporate our operational realities wherein there is not a lot of RT-PCR available, and that the evidence now is still to not separate and to continue breastfeeding. And so to do that, next slide please, we activated the guideline development process, but this time we did it in a rapid, it's a rapid process. So here, identified priority algorithms for review. So we tagged the maternal and maternal newborn care as primary, as a priority algorithm. So how did we scope the evidence? We scoped the following evidence systematically. And very important here would be the key informant interviews from relevant stakeholders, as well as feedback synthesis from the Viber support groups. So next slide. And then we sat down with technical experts and we drafted the recommendations based on the evidence, and we drafted the algorithm. And then after we've done that, we did a stakeholder consultation. So the first draft was circulated through targeted stakeholders. All of this via phone, via Google Documents, via email, via Zoom. It's all remotely. So the target audience would be not just the obstetricians and pediatricians, because they already have developed that and they were already in conversation with the DOH at that time. So we targeted now the primary care providers. So we targeted the health managers, the frontline health workers, the GPs, nurses, midwives, patient support groups, and experts in MCH and UN agencies and other NGOs, and health policy specialists and academia. All right, so next slide. So what are the features of our recommendations? So the features would be, the first is you make the right thing easy. Make the right thing the easy thing. So we simplify the flow and format. We use an international a standard that is consistent across, so that if a midwife would learn how to read one algorithm, she would be able to transition to the next algorithm without having to have that mental burden. So, and then we put in evidence-based guidance as default instead of opting out. For example, I think the AAP would say, okay, if there is temporary separation of the mothers and babies, but there can be an opt-in. Here, what we did was the baseline would be evidence-based guidance, which is unang yakap, or the first embrace, non-separation. And then if the mother would opt out, then there would be explanations for an informed choice, and then they can opt out, right? So, and then number two, we de-emphasize RT-PCR testing in decision-making, because testing does not really change clinical management in the immediate care, given the current format of evidence-based guidance. And the results should not come in the way of sound clinical judgment. Because from what we've been hearing, many health workers are stuck in the absence of RT-PCRs, and this should not be the case. All right, so last is the shared decision making as a feature. Next slide, please. All right, so this is just an example of how to use the algorithms. I will not go into the details of this, and I hope to make the algorithms available to everyone. But very quickly, the consistency, like we have a clinical state, a decision box, action box, and a connection box. Next slide, please. We tested this with the midwives also, and they've been using this and they see that it can be clear, because it's just like here, when you classify cases, does the patient have acute respiratory infection? And then if you go by this, it's a yes, you go to the right. And then if no, you go to the, you go down, and so on and so forth. And so you see here that they're numbered, so it's easy to refer to them. So if you end up in a hexagon, it means you need to make a decision. And if you end up in a box, it means you need to act. And if you see an oval, it means you need to connect with another one. So all of the algorithms are shaped this way. Next slide, please. All right. All right, so this is just an example of what we did for the pregnant patients. So as I mentioned, number 2 is an oval, so it's a link to another algorithm. And number 7 provides usual care in situations where you're dealing with a non-COVID pregnant patient. So there's a provision for that. So it integrates the new normal. Next slide. All right, so here you just see box 8, 9 to 8 and 9 would be allowing for referrals. Box 12 would be birth planning, and 14 to 19 would be shared decision making. So all of these, if you look at them, they look complicated a bit, but actually when you read them, they're very simple instructions. Right, next slide. So here, it's very important here. Can you please go back up? Here, when you look at the algorithms here, there is no bottleneck for the RT-PCR. Next slide. All right, I'm in my last 2 slides, I think. So this is now for the newborn, wherein you see here 1 and 3, you have a linkage with the previous algorithm, and number 2, you default on evidence-based practices. Here, number 2 is non-separation. And here, for the decision-making, the mother prefers non-separation. And all of the informed choice comes in after. Next slide, please. Right. Here, again, slide 7 to 10 is shared decision-making. Why did we have to expand these boxes? If you look at how informed choice is done or consent is done, oftentimes it's just really, you just, sometimes in a hurry, many health workers would say, oh, if you don't separate your baby, he will get the virus from you, or we don't know. Sometimes the way that informed choice or the decision making is communicated, it may not necessarily be consistent. It depends on how the health workers say it. So here what we did was to ensure that the way it's communicated allows really for that choice to be made in a way that that is empowering and not out of fear as a waiver of right. All right. So okay. So next slide. I think that's about it. So the key messages here I would like to leave with everyone is that health workers need practical guides for COVID-19 response, because if not, the knee-jerk reaction would be fear. There's a need to balance personal safety, well-being, and provision of quality care. And we know that quality care can be compromised during these times, and therefore clinical practice guidelines can be a tool in improving quality of care by making evidence, a rigorous review of evidence to see if we are making harm or if it's beneficial. And here you see there's a clarity in decision-making process that results in efficiency. And lastly, here we've shown in the Philippines that technology was able to facilitate our CPG development, dissemination, feedback, and updates. So what we also want to emphasize here is that when we do these guidelines, rapid recommendations should not bypass stakeholder consultations, because it's really doable to consult with the right stakeholders for as long as there's somebody who would facilitate that. So I think that's it. Next slide, just for the acknowledgement. I would like to acknowledge the following. Many people have worked with this. And next slide, please. The last one. Yeah, so I'd like to thank the following colleagues for also helping me out with this presentation. Thank you very much. That's it.
Thank you very much, Lei. This was really in-depth and I think very useful, hopefully to many of the people who are attending. I think I see nearly 200 people are listening keenly. So if you're ready, we can start with some of the questions that are coming in. To those of you who were not there at the beginning, there's a Q&A box at the bottom of your screen where you are able to type in your questions. So I'll start with the first one from our colleague Therese Delvaux from ITM. And I think probably a question that many people would have liked for you to speak to, which is, to what extent did you consult women and families in this process, and how?
Right. So that's a very difficult thing to do at this point, right? So thank you for that important question. So here in the Philippines, we have mother support groups already that have been organized pre-COVID. Many of them would be very accessible online. I think if you would like to ask a show of hands, maybe some of them are here. So these are mother leaders who usually have their their own place of influence, and they're able to gather insights from the other mothers. Of course, that's from the online segment. The other is we work with community. We have had very limited interaction with urban poor through partners in the community. There are community organizers we've been working with, and they are really in touch with the 4Ps. 4Ps in the Philippines, they're recipients of a government aid, conditional cash transfer. And so we have access to them, and we really interviewed them. And we were able to get insights based on those remote consultation. Yeah, I hope I can answer that more in depth, but yeah, just.
Great, thank you. I'll move through the questions if you don't mind, so that we get the most questions covered from participants. The second question is from Natasha Julian Delgado, and she's asking whether you have any data on how women and children living with HIV are being affected by the pandemic. I think from her experience, it seems that there was a stoppage in the supply of ARTs.
That is very, thank you for that very important question. Unfortunately, from my end, I have been blinded to this. I have not really been in touch with colleagues working on this, but thank you for raising that very important concern. I am not able to answer it right now for the Philippines.
Great, thank you. Then another question is asking, is the transmission risk not bigger from healthcare workers to patients than from mothers to newborns?
That's a very interesting question. And in fact, that is also one of the things that we are, in fact, there have already been cases that, the mother is COVID negative in RT-PCR, and the baby is positive. So, well, there are many possibilities for that, and that is very important. And this plays a big role in terms of risk communication also, because it doesn't mean that if the baby is separated from the mother, it doesn't mean that transmission stops, because transmission can also happen when the baby is separated from the mother. And I think that's the heart of the question. I hope I answered it.
Yes, thank you. The next question, I think quite relevant, is how do you minimize the risk of spreading COVID while training health workers on these algorithms?
Right, it's a very interesting question. So just to share, we have already had runs with provinces on this. So we have a module just to teach health workers on how to use the algorithms. It's very interactive. We use Zoom. So it's really just Zoom. And so there are case scenarios and they do polling. So we are able to do it even if we're in Manila. We're able to prepare provinces. So these are provinces with multiple municipalities. We're talking about like, multiple municipalities. And we've seen that when they do the algorithm training, and we will be making those modules available also publicly. Maybe we can share through Lenka. They have this interaction and they provide good feedback in terms of it helps them in the decision making. So I think to answer that, we use Zoom, and then we also have partners that ensure that the health system, the health actors have access to internet and to devices that would allow that interaction. I think that's it.
Great, thank you. A question from Nazgul Samieva.
Hello, Nazgul.
From your experience, how useful were digital technologies in mother and childcare during COVID?
It's very, very important. Actually, since the policy, remember the separation policy has been in place since I think around March, and we've been working on the update, and many of the babies were separated, and because of that, you need support in breastfeeding. And many of those who provide support in terms of breastfeeding have been mothers themselves who are online. And so there are online mother support groups who come together to support these mothers whose babies have been separated or those who have been orphaned. In fact, the mother that I showed in the headlines, the mother support groups, and I would like to acknowledge Dr. Mian Silvestre here. She's working with them very closely, and then they actually come up with donations for breast milk so that they can also send to them. So there's this network, really a remote network of mothers helping other moms, and it's all online. So yeah, it has been a tremendous help.
Mm-hmm. Mm-hmm. And perhaps a very related question in terms of the use of digital platforms and technologies is, what about the safety of the information that is being shared, and have you taken any measures to perhaps keep safe the private or sensitive data?
Right. There are so many layers to that question, I think. But for now, the online platform, the Viber groups remain. Like, for example, I think that's a possible breach, right? So it's very convenient right now to use Viber for the technical working groups. And then Zoom, what people do now is to really just log in, and but it's still the one that's being used. And so, for example, for other institutions, like for example, the Ministry of Health, the Department of Health, they use a more secure platform. So it really depends. Like if you don't have a budget, then you use Zoom. Let's something like that. So it really depends on each organization, and the risk is always there, I would say. And I think, yeah, that has not been addressed for most of the technical working groups. Yeah.
Right. And perhaps a question that is relevant to the finances surrounding the COVID pandemic is a question from Karina Vidovati, and she's asking if the COVID test is required for a mother who refused separation, who is going to pay for the test?
Can I clarify the question?
If PCR testing is required for a mother who refused separation, who is going to pay for the test?
Oh, that is what we are trying to fix for the policy, because right now in the Philippines, you really cannot do PCR ASAP. There's very limited testing capacity. But now it's out of pocket for now for the private providers. So it's out of pocket, and there are already packages, PhilHealth packages that are being developed for this. I have to clarify, I have to confirm if they have been updated for COVID already. But yes, it's out of pocket mainly for now. But that's what we're trying to do now, to not make it a requirement. So yes, I think I answered it. Yeah.
Yes, thank you. The next question is, I understand from the presentation that 45% of births are in health facilities.
Right, so.
Yeah, and so the person is I guess asking whether the percentage of births that are happening in health facilities has changed during, has it gone up or down?
We don't have data on that yet. So what we have is an estimate. In fact, when we were looking at the data, we actually do not have, as far as I know, updated data on how many are actually giving birth at home, or how many are giving birth at tertiary facilities or in lie-ins. What we have is an estimate based on a particular region, but it could be higher. It could really be higher. So we don't have trends yet since post-COVID. It would be very interesting. I could already predict that people would be pushed down to the primary care facilities, even back down home. So it would be interesting to look into that.
Right. Thank you. And perhaps we are coming. There is a question and many thank yous in the Q&A asking whether the algorithms might be available online or how people can get hold of them.
Right. It's an ongoing process right now. That's why we're not making them available yet. So we hope to hear from very soon. So we will be making them available as soon as possible. And perhaps for the recommendations, because these are not the ones that are adopted by the Ministry of Health, the Department of Health. For that, perhaps Dr. Lenka, maybe we can share that with you, and for those who will be interested. So definitely we can share them. So yeah.
Okay. Perfect. And perhaps I'll take the liberty to ask you the last question, because we are coming to the end of our time together. But in the bigger picture, I suppose, do you see any lessons that this pandemic, any lessons that we've learned through this pandemic that are going to help us for the future in terms of improving maternal newborn health, breastfeeding? Things that we can do better, faster, more collaboratively, more innovatively, perhaps, from your experience?
Yeah, thank you for that. I think what we really learned here is the importance of a clear, explicit way of deciding on what policy makes it, or explicit way of evaluating how policy is made, and that kind of guidance. That's very useful for a time when people are confused, because if you come up with 10 different guidelines from everyone, then everyone in the front lines is confused and the patient suffers. Not only the patient suffers, but also the health worker suffers. You don't know what to believe in and you don't feel safe. So the knee-jerk reaction is really to act in fear, and that's not good for the well-being of health workers and also for the patients. So I think that's very important to have a process by which health systems can harmonize guidance and facilitate the consultation, not just by one or two people, but really consultation that would facilitate buy-in and dissemination and implementation. So I think for me that has been the lesson learned throughout this journey, and we're still learning. We're really still learning. But I'm proud of what the medical societies have been doing. It's not just in the front of the maternal and child health, but even in terms of return to work guidelines, because there's a lot of controversy in terms of how do you use now rapid antibody tests, etc. So there's been a lot of push and pull in terms of what to follow in terms of guidelines. And of course, different sectors have also their own take on things, but we have to stand by public health. We are the ones protecting the population, and so we need to really collaborate, harmonize, make our voices louder, and work efficiently so that the guidance will come from us, and there's that process safeguarding it. Thank you.
Thank you so much, and I know you are really in the middle of this work, so we really appreciate your time and the thoughtful way in which you've shared your experience with us. And I'm sure I speak on behalf of all the participants today. So I wanted to say thank you to you, Dr. Lei, and thank you for all those of you who have joined. And I know that includes many people from the Philippines. So thank you for staying up for this presentation, and hopefully lots of different health providers and also mothers. So thank you very much for joining us today, and the recording of this session will be made available as Charlotte said previously. Charlotte, would you like to add anything? I'll hand over to you to close.
Thank you to all for this very interesting presentation. Lei, thank you for sharing your experiences and expertise. And I would like now to invite all the participants as well to give their feedback on the webinar. Thank you also to Lenka for your moderation, and thank you to Jan as well for his technical support. So we are looking forward to seeing you to the next webinar. Thank you.
Thank you.
Bye-bye. Bye. Thank you.